And now we have even up to gene therapy and gene editing is coming up. So previously we have the palliative transfusion. When they had anemia, they give transfusion. Then came the hyper transfusion, super transfusion, and all these things, which we studied during our postgraduate days. Now the transfusion regime is a moderate transfusion where you give the pre-transfusion hemoglobin at 9 to 10 and post-transfusion around more than 12, but less than 14. It should be less than, not above 14. So that is the moderate transfusion that we advise for proper growth and for a child. In thalassemia major, you transfuse as early as possible because they present at 6 months, so you don't have to wait. While in thalassemia intermedia, it is very important. A child who presents after 1 year, you don't have to jump into the transfusion. You want to identify the phenotype. You want to know whether this is am I dealing with the thalassemia intermedia or not. So you can wait because some of the thalassemia intermedia may not be needing transfusion. They may be what you call, they may attain a normal height. They may not be transfusion dependent. They can go on living at a hemoglobin of 7 to 8. So you don't make a thalassemia intermedia into a thalassemia major. That's one mistake many do. They when you diagnose thalassemia intermedia, they jump to transfusion and make this thalassemia intermedia into thalassemia major. So that is one thing which I would like to say, and we have to work up for other transfusion associated infections like HIV, HPV, HCV, etc. This is the moderate regimen which I already said, that is 15 to 20 ml per kg. Average you have to have 3 to 4 hours, and it is always important to use gluco-reduced RBCs, which we are giving. This bedside filters, leukocyte filters are available, and which can be procured through our government schemes. And we are using that gluco-reduced RBCs. It prevents alloimmunization, non-hemolytic febrile transfusion reactions, and even CMV infections. So it is very important, pertinent to use because they are on. It's a every month they come for transfusion, so you don't have to. It's very important not to have them alloimmunized. And this we already know that if they need more than 200 ml per kg per hour, you have to think of hypersplenism, alloimmunization, GI bleed. So this is other things that you have to look for. So always have a record of all the transfusions in the book and see whether they are really needing how the transfusion is going up. And the other thing is that transfusion, it is in thalassemia major, the main cause of the iron overload is the transfusion. While in thalassemia intermedia, because they are not iron overloaded, because the main cause of iron overload is from the absorption. And thalassemia major and intermedia basically are what I call multi-organ disorders, because they are not hemolytic anemias per se. They are not only hemolytic anemia, they involve the heart because of the increase in iron accumulation. There's the cardiomyopathy, liver is in all the endocrine organs are involved: pituitary, thyroid, parathyroid, pancreas. So it is very, very important to have a comprehensive care. And some of the most important organ that they have to be what I call safeguarded is the heart, because the most common cause of death in our, like I have seen before the chelation, right? Like when I started taking up this treatment of thalassemia, most of they were every year, they were just before that, every year children were dying because of the cardiac failure. So if you have the prevalence of, if you have chelation, there is a what I call increase. If you fail of chelation, there is a 63% increase in uh, chance of death due to cardiac failure. So iron chelation is very, very important. So you cannot have only one limb, you have to have two limbs, that is chelation as well as transfusion. So iron chelators we have three iron chelators. The the latest is the Deferiperone, and the oldest is, and the gold standard is the Deferiperone, and we have the Deferiperone oral. So two oral and one injectable. And just to say what is chelation? Chelation is, that is, a chelator binds with a toxic metal to make it more soluble and excreted via urine or feces. So that is chelation. And this is the history of chelation. Initially the desferrioxamine, then initially it was given IM, then IV, then came the Deferiperone, then the Deferacerox. So it's evolved over from 1962 hours to 2020. So this is desferrioxamine given subcutaneously through a pump. How the compliance can be very low, but still it is the gold standard. And you have the Deferiperone, which is a oral drug. The problem with this is agranulocytosis, it a rate limiting erosive arthropathy. So these two things are very rate limiting, and it has to be given thrice daily. Then came the combination of this Deferiperone and desferrioxamine and shuttle. It's a shuttle hypothesis, and so that this can be given only 3 days, and Deferiperone can be taken all throughout the week. Then this came, which was a boon for the thalassemia patients because this could be taken once daily. It has to be taken early morning, and and but the promise of Deferacerox was so high that basically it becomes an anticlimax. Like തുടക്കത്തിൽ അവർ വലിയൊരു ഡ്രഗാണ് വിചാരിച്ചത്. When everyone's very high, the most of the studies which the pharma companies they have shown that it has a very high what you call chelation effect and all this, but that within 3 months or 6 months. But in reality, when we also started giving Deferacerox, it took around 1 year for the iron to fall down, iron level to fall down. So basically, it is one of the best things that have occurred, but not the best thing for the thalassemia patients, because it has side effects like gastritis, hepatitis, rash, and all these things. And the chelation is slow in Deferacerox. So it is 5 times more efficient and mobilizes cardiac and it is FDA approved. So this one drug which I would like to introduce is Hydroxyurea, because once you diagnose thalassemia intermedia, that is, many of these children benefit from Hydroxyurea, especially if they have a certain mutation. So all thalassemic children, intermediate children, it is better to start Hydroxyurea. The rate, you start with the 10 milligram per kg and do not exceed for 20. And I have what you call stopped transfusions in quite a few thalassemia because they were on regular transfusions. When I took the history, then I found out that most the phenotype was it was a thalassemia intermedia, started Hydroxyurea, and most of them are not on transfusions. And other things that you have to do is to always follow up. So any chronic illnesses in pediatrics, the follow-up is one of the most important things. So if you don't follow up any chronic, so in this case also follow-up is very important. You have to follow. These are some of the 10 tests that you have to do, especially, and all the endocrine tests you have to do after 10 years, and you have to look at the growth monitoring. Yeah, Dr. Narayan has said about immunizations, and all these things has to be taken care of. They might have diabetes. Okay. So, and also look for hepatitis B and C. And one of the recent investigation that has come is the T2 star MRI. I have been trying to procure it. The cost is so exorbitant. Tried with what you call. I even tried whether we could do it. Somebody can hack I don't know whether I should say it here, but some programs, whether it's a program which has to be bought. And if you have an MRI 1.5 Tesla, you can do it. This is one of the best investigation for tissue iron, especially the liver and cardiac iron. So this is what we do up till now for the supportive care. And very important, if they have a relative who are fully matched donor, and it is very important that they go for transplant, especially if they have if the facility is there, and if they can afford, especially early in the phase, because the cost of transplant is less than the total cost of chelation and transfusion, the lifelong chelation transfusion, and survival is very, very high, especially after a allogenic sibling match. If you have a allogenic sibling match donor, and the problem is the probability of finding a donor is very low, especially we are having a more and more nuclear family. Now this is the Lucralis classification. So they have to be taken up for this is class 1, where they have their regular chelation. Class 2, if you have parameters. If you have hepatomegaly plus that indicates that they are class 2. If you have all these three things are there, that is chelation is irregular, hepatomegaly, it comes to the class 3 Lucralis classification. So the prognosis is bad if they have a high ferritin, huge hepatomegaly, and liver fibrosis. So that's very important to say that. So they have to be taken up for transplant. Now the Coal India project was there by Government of India, and many children are now being taken up a transplant in Vellore and other centers. So other thing, because of the small family, we have seen that some centers are now taking up haploidentical haploidentical transplant in thalassemia as well. But the prognosis is not so high as in the allogenic sibling match donors. And this is one drug which has come out in US and FDA in older patients. That is, it reduces the it's called luspatercept. So this is uh, there are luspatercept is it acts as a ligand to trap to the it blocks it blocks the inhibitors of late phases of erythropoiesis. So inhibitors of late phases of erythropoiesis are blocked or trapped by this luspatercept, so that they go into they evolve into a mature erythrocyte. So this is the study that came in blood, and they had 64 adult patients, and it was injectable. It's an injectable drug, so given every 3 weeks, and every patient, even transfusion dependent and non-transfusion dependent thalassemics, had a rise of hemoglobin because of this drug called luspatercept, and it will be coming up in India too. One important thing that I would like to say is that there was, which really exciting, is gene editing. Then because gene therapy, we have been studying gene therapy from the very beginning when we have studied PG level. Ashok Kumar sir would have sir ഓർമ്മയുണ്ടാവും. അന്നേ തൊട്ട് recent advances is gene therapy. But the gene editing is now coming, and we have one patient. So they have tested one patient who had uh, thalassemia major, who are regular transfusions. Now that person is off transfusion and independent. He's transfusion independent with a total hemoglobin of 11.9. And gene editing as with the CRISPR-Cas gene, that is CRISPR-Cas enzymes. They just like നമ്മളുടെ നമ്മളെ ഇതിലൊക്കെ വേർഡ് എഡിറ്റ് ചെയ്യുന്ന പോലെ, കട്ട് ആൻഡ് പേസ്റ്റ് പോലെ, you can cut the gene, abnormal gene, and then keep the gene that you want in that place using the Cas gene. So this gene editing, it is the in thing അത് വരാൻ പോവാണ്. It might revolutionize the management of many of the rare diseases, and as Dr. Narayan has said. So antenatal screening is very important. I just started. I don't know, but it didn't come up, and screening of all pregnant women. So you can screen if there is a very high incidence of thalassemia, you have to screen all mothers. And in Cyprus, it said that before you marry, you have to screen yourself whether you are a thalassemia minor or not. So all the what you call all couples have to get their certificate whether they are thalassemia minor or not to prevent the thalassemia major. So in the same way, you can screen antenatal, and if they are both, the mother is a thalassemia minor, and you have to screen the husband or the partner, and then look if they are if it's still thalassemic minor. If both of them, they have to counsel, then you have to advise chorionic villus sampling or amniocentesis to look at the mutations. This one area which I'm interested, because the they have to be regular. When from early onwards, like from the age of 6 months onwards, they come to the hospital every month or twice a month. So pain during process, every cannulation, school absenteeism, scholastic backwardness, need for continuous medications. All these are disabilities which we have to look at as a pediatrician, because we have to have an empathy for them. They may be short, they may have short stature, abnormal faces, abnormal looks, tiredness. They may have psychology. So to be you have to have a comprehensive approach to this patient, not or just chelation or transfusion. You have to take them into your fold. And for parents, it is finance, loss of work, because they have to come here. And also we had broken families, and there was a parent whose uh, older child was not thalassemic, but he had other two children who were thalassemic. This girl was not thalassemic, but ended in a divorce. So then fear of the next pregnancy, stress in the family. So all these things has to be. So you have to have a multidisciplinary team with nurses, psychologists, physiotherapists, social worker, and all things. We have a two social worker. Krishnamurti chips in from IMHANS for psychological counseling and all. So definitely there is a multidisciplinary, and if there is a pain, Dr. Geeta comes. So she is interested in pain management, and we have to. So this is one area that we have. So all children. Dr. Asha was saying that up to 18 years we have this chelation free because of the government schemes. But after 18 years they have to buy their own. They have to buy their own chelation drugs, and this is very important. So it is important to have chelation drugs available for after 18 years, and prevention of birth of a thalassemic child. And all I think all medical colleges should have a hematology unit for, or someone who is interested in. Now in Thrissur, Sheila is interested in Trivandrum, Dr. Shankar is interested. So all medical colleges, they are very, I think they are good in treating it. And this is our that occur. That's we have all. I mean, we have competent therapy. All these things are available in, but this has to be translated to the district. This is for the IAP to take up. So all the facilities for the treatment of supportive care should be taken up to the district, to the taluk level. So the IAP leaders can take up, so that treatment of rare diseases, they need not come to the medical college level. So some of the transfusions, chelations can be done at the district, and training of pediatricians and population awareness and school interventions are very important. And this is another future needs insurance, because in private hospital, some of the insurance, they don't give insurance if they have a genetic disorders. And also you have to have more BMT centers, and you have to give them disability certificates for their. These are the organizations that work with thalassemias. And with COVID and thalassemia, just few FAQs, because now is a COVID season. So are patients with thalassemia more susceptible? The answer is no. They are not more susceptible. This is because in Italy, there were a group, because Italy is one area where you have a lot of thalassemics. Italy, so they have a group of thalassemics, which actually they studied the group of thalassemics, and it was really, they didn't have a severe COVID. And does splenectomy confer a higher risk? No. Basically, splenectomy does not confer a higher risk for viral disorders, but they may have more of a bacterial disorders. Should thalassemic patient continue iron chelation? Yes, definitely, and it does not increase the chance of being a severe. And what are the basically stem cell transplant? They have to postpone. So these are the FAQs. These are our beauties, and see the thalassemic children. And you would remember the Arushi. She's here now. She's looking like a model, and see that. And these are young boys and girls, and during the thalassemia day. And these two photos are very dear to me. She's a thalassemic, and she had married and given birth to another child. And this is another what I call feather in the cap of the department, basically, I would say. And she has just what I call joined our medical the MBBS in Calicut Medical College. And she's we are very proud that one of our thalassemics has become going to be a doctor. So thank you very much, everyone, for listening, all the teachers. And this is our corridor to a hemato-oncology ward. And what is this corridor? I think many of you would have seen the corridor of Rameshwaram Temple. Thank you.
Thank you, Dr. Ajit. That was an excellent talk. Very concise, and regarding the newer things that are available. My question is regarding hydroxyurea. How long do you give hydroxyurea, and have you come across any side effects or reactions to hydroxyurea?
Basically, hello.
Yes, I can hear you.
Yeah. So hydroxyurea, the problem is you have to monitor the total count, and they have to be monitored. Without you start with 10 milligram per kg, up to 20, beyond 20 you should not go in thalassemic children, and that should be only on thalassemia intermedia, and look at how they respond, and how, because most of the thalassemic might respond, but some may not be responding. So we have few thalassemia intermedia who are in the, as I said, in the other spectrum, near the major spectrum. So in that, they may not be responding, and we have seen less side effects than expected. We don't see much side effects in hydroxyurea.
How long do you give it?
I mean, it is basically thalassemia intermedia. It is lifelong. You give like that. So that's why I was not scared for giving it, because they are really off transfusion and then going to school, and they don't have much side effects.
That's why I asked the long term, what are in your experience? Because I have a child with thalassemia who is on hydroxyurea having very good results.
Yeah, they don't have much of a. I have not seen any side effects because of the hydroxyurea in these children.
Okay, thank you.
Ajit, I am Dr. Sasidaran.
Sir. Good evening, sir. Kandilla, sir.
I was here only
Okay.
from the very beginning.
Okay.
I want to remind you a few things. I think we were not fortunate. We were really experienced in managing a lot of thalassemic patients. Most of them came from Widen, especially the Kurchias. And Dr. Surendran, I saw him, his photograph. He is one of the person involved in that. And almost 20 years back, there was a big project by Dr. I.C. Verma. They did the genetic studies of all those who turned out to them. And he has given pink card for all these individuals and advised them not to marry in between. He came here and I was with him there those days. And whenever somebody comes to baby member hospital with thalassemia, we used to get patients. I asked them, do you own a pink card? Yes, sir, we have a pink card. Then why did you marry? Said there is no other way. I think this is a miserable situation. If that pink card system they literally followed, we should have totally wiped out this problem of this clinical manifestations of thalassemia in children. So please keep this also in mind. To once you go for testing, let us face the carriers and advise the carriers not to marry in between. This is because you have described everything in detail. It's a very miserable problem coming for transfusion, getting reactions of transfusions, growth retardation, spoon failure, and you also cited an example of breaking the marriage and all sorts of problems we come across. Anyway, that's a very nice talk. Thank you very much. Okay.
Thank you, sir. Sir, either Cyprus, they are doing it. So the
Yes.
problem is, if they, sir, പറഞ്ഞ വളരെ നല്ല കാര്യമാണ്. പക്ഷെ അവര് ലവിലൊക്കെ ആയി കഴിഞ്ഞാൽ എന്ത് ചെയ്യും?
കാർഡ് നോക്കിയിട്ട് ലവ് ചെയ്താൽ മതി.
ഷാജി പറഞ്ഞ പോയിന്റ് ശരിയാ. That doesn't last longer as before.
Dr. Ajit, can I ask you a question?
GK സാറിന് ആദ്യം നോട്ട് ചെയ്തില്ല സാർ. അശോക് കുമാർ സാറിനെ സുധാകരൻ സാറിനെ ഒക്കെ അക്നോളജ് ചെയ്തിരുന്നു. സാറിന്റെ പേര് ഇതിൽ ചനിയിൽ ശശിധരൻ എന്നാണ്. അപ്പൊ വീട്ടുപേര് ആദ്യമായിട്ടാണ് ഞങ്ങൾ കാണുന്നത്.
I was enjoying it from the very beginning.
Okay, sir, welcome.
Dr. Ajit, can I ask you a question?
Yeah.
I'm Suresh here. Okay. Actually, I wanted to ask you, if the patient is on high dose of Deferiperone, is there any reason, or can you give IV chelation in between?
Definitely. That's Suresh. Now, just like the shuttle hypothesis, Deferiperone plus Deferiperone. Now, there are many papers combining this new chelators like Deferiperone with the Deferiperone. Or if you have a child who is the ferritin level more than 4,000 and you think that there could be a cardiac toxicity, then you can combine Deferiperone with Deferiperone, or you can combine Deferiperone with Deferiperone. So now many papers are coming with combination in these two areas. But
Thank you, Ajit.
Yeah.
Thank you, Ajit. And another observation, which actually my friend from UK shared, he was working in a hematology unit, and in his unit, most of the patients are COVID positive, and everybody around is COVID positive. But what he observed was the hematological patients like thalassemia, sickle cell anemia, all those people had some sort of protection from getting COVID, and even if they get COVID, only very minor illness. According to him, he didn't see any very severe COVID cases among these hemoglobinopathy patients. Just wanted to share this.
That was the report from Italy. Italy, they had because Italy was the worst affected area for COVID, and they had a lot of thalassemics there, and they have found out that most of them were not severely affected. That was one thing. Maybe this.
Thank you, Ajit.
അജിത്, പിന്നെ നമ്മൾ ഈ ഡെഫ്രാസിറോക്സ് വെള്ളത്തിലോ ജ്യൂസിലോ മറ്റോ കലക്കി കൊടുക്കണമെന്നാണ് പറഞ്ഞത്. അപ്പൊ അതിൽ മെറ്റാലിക് സ്പൂൺ ഒഴിവാക്കണം, അങ്ങനെ എന്തെങ്കിലും ഉണ്ടോ?
അതുണ്ട്, മെറ്റാലിക് സ്പൂൺ ഒഴിവാക്കണം, ബിക്കോസ് ഇറ്റ്സ് കീലേറ്റർ, അപ്പൊ അയണായിട്ട്. സോ മെറ്റാലിക് സ്പൂൺ ഒഴിവാക്കണം. അത് രാവിലെ കഴിക്കണം, ഭക്ഷണം കഴിക്കണത്തിന് മുമ്പ്, 1/2 മണിക്കൂർ മുമ്പ്. Just be stirred and then now studies are there where you can even give twice daily. Basically, previously it was once daily. So that's why I said it was a very promising drug in the initial, but now it is saying that you can, if the ferritin goes high, you can give twice daily as well.
ഡെഫ്രാസിറോക്സിന്റെ adverse effects ഒന്ന് പറഞ്ഞാൽ.
Most common is rash. Most common rash ആണ് maculopapular rash. Hepatitis, we have seen hepatitis, and gastritis is another thing. So
agranulocytosis.
പിന്നെ non agranulocytosis വളരെ rare ആണ്. Agranulocytosis is very common with Deferiperone. But here we have hepatitis, so we have to stop the drug. And rash, I think we need not to stop. Then one other side effect that usually described is the increase in serum creatinine, non-progressive increase in serum creatinine, which you have to follow. So every child with on Deferiperone has to be RFT and LFT has to be monitored.
What about Stevens-Johnson syndrome?
Stevens-Johnson കണ്ടിട്ടില്ല. ബാലന്ദ്രല്ല വിളിച്ചത്.
Shaiju?
I have not seen Stevens-Johnson. I don't know.
Hello. പോസ്റ്റ് ചെയ്തിട്ടുള്ള ക്വസ്റ്റിന്റെ ആൻസേഴ്സ് കിട്ടിയിട്ടില്ല കേട്ടോ സാറേ. പോസ്റ്റ് ചെയ്ത ക്വസ്റ്റ്യൻസ്
അത് ഞാൻ നോക്കട്ടെ.
അല്ലെങ്കിൽ ഞാൻ പറയണോ?
അജിത് വേണേ വായിക്കാം, ക്വസ്റ്റ്യൻ വായിക്കാം. Informative talk. Thank you, Ajit sir. And the IAPS suggested by sir, pediatrician in government service need to be trained in follow-up and care of monitoring. Excellent presentation. Do the children post-transplant continue to have high ferritin? Do the children post-transplant continue to have high ferritin?
Yeah, that is very important. That there are many papers saying that before you take up any child with thalassemia for transplant, you have to have intense chelation, so that the transplant goes well. And those whose ferritin is high just before transplant, they do very badly. So one thing is, before transplant they have to be chelated intensely to reduce the ferritin level, and after transplant also it takes some time. They may have to be chelators, but it gets, especially thalassemia major, they may have to be given for some years. The chelation has to be given, because the tissues and all, you're dealing with there is some amount of increased load into the tissues already because of the long duration of transfusion regimes and all this. But if they are being transplanted very early, you need not you not give it for a long time. You have to monitor the ferritin level.
എനിക്ക് എൻ്റെ ഒരു ഡൗട്ട് ഞാൻ ചോദിക്കാം. ഞാൻ ഡോക്ടർ ബെന്നറ്റ്. ഹലോ, സംശയം ഇതാണ്, നമ്മളിപ്പോൾ ഒരു ചൈൽഡ് വരുന്നുണ്ട്, സേ അറൌണ്ട് ദ ഏജ് ഓഫ് 2 years or 3 years with pallor. Clinically, you diagnosed as an iron deficiency anemia. Clinically, where hemoglobin is reduced. Is it necessary that you have to do the ferritin level, transferrin level to rule out other things before giving iron therapy, or straight away you can give iron therapy, especially if the spleen is not there?
Yeah, that's a very good question, Bennett. Now, common iron deficiency element. You can safely give iron for 1 month and then look at the increase in hemoglobin.
Okay.
1 month you give iron and look. So what they said, that's one of the best tests to look for iron deficiency. You give, that's a trial. That's what you call give iron for 1 month, then look at the rise of hemoglobin of 1 gram per this one, and then see. If it is not increasing, you think of few conditions. One is thalassemia. Second is compliance, reduced compliance, or increased loss, and all these things.
Okay, appa trial aayittu kodukka without much evaluation alle?
No, yeah, definitely. 1 month you have to, you can.
Thank you.
Chat box il Geeta Govindradinte oru comment undu. Too often ignored area thalassemia management are caregiver burden and the problem of siblings. Siblings can have problems like attention seeking behavior, sibling rivalry, emotional disorders, needs attention. Caregiver's burden is something which we should pay attention.
Yeah.
Krishnakumarinte area aanu.
Parent burden parnu. Parent, I have talked about the burden of parent. I have talked about burden of children. But thankfully, Geeta point out that the parent, the sibling, actually, it. At a കൂടുതൽ കാണുന്ന leukemia patients, cancer patients ആണ് ഈ sibling rivalry. Thalassemia patients അത്ര sibling അവർ ഒരു ദിവസം വന്നിട്ട് transfusion എടുത്ത് പോവാണല്ലോ. But in leukemia patients, they are admitted here with a parent ഉണ്ടാവും, ഇവിടെ ഒരു 6 മാസം ഇവിടെ തന്നെ ഉണ്ടാവും. So other child is not taken care by relatives or grandmother or grandfather or someone. In leukemia patients ആണ് കൂടുതൽ ഇങ്ങനത്തെ sibling problem ഞാൻ കാണുന്നത് than in thalassemia patients, because thalassemia patients, they come here then very അവരെ jolly ആയിട്ട് വന്നിട്ട് I mean they have a group, ആ group ഒരുമിച്ച് വന്ന് transfusion എടുത്ത് പിന്നെ തിരിച്ചു പോയിട്ട്. So maybe that's one area which we have to look into. Thanks, Geeta, for. But I have seen more in leukemia patients. I have seen it more in, because for months and long duration of chemotherapy now.
Ajit pointed out difficulty in getting chelating agents after the age of 18, because Thalassemia scheme is up to the age of 18. But one of the problem, Thalassemia is implemented by Social Justice Department. The beneficiaries under the Social Justice Department are children, women, old age, and disabled. അപ്പോൾ മുമ്പ് ഇപ്പൊ തലസീമ ഒരു ഡിസബിലിറ്റിയിൽ വന്നിട്ടുണ്ട്. നമ്മൾ മുമ്പ് ട്രൈ ചെയ്യുന്ന, ഞാനൊക്കെ ഇരിക്കുന്ന സമയത്ത് അത് ഡിസബിലിറ്റി ആയിരുന്നില്ല. അപ്പൊ 18 അപ്പുറം എടുക്കാൻ പല പ്രാവശ്യം ശ്രമിച്ചിട്ടും ഫെയിൽ ആയത്, അഡ്മിനിസ്ട്രേറ്റീവ് ലെവൽ അത് പറ്റാതെ പോയത് 18 വയസ്സ് കഴിഞ്ഞാൽ ചിൽഡ്രൻ എന്നുള്ള അത് പോയി. അപ്പോൾ സോഷ്യൽ ജസ്റ്റിസ് ഡിപ്പാർട്ട്മെന്റിന്റെ കീഴിൽ ബുദ്ധിമുട്ടാണ്. പക്ഷെ നൗ തലസീമിയ കം അണ്ടർ എ ഡിസബിലിറ്റീസ്. So we can try, IAP can press on that. Even after 18, it may be considered under the heading of a disability.
So
another,
okay.
Another comment goodi Vijaykumar endo idinde. All children should be followed up with a growth chart.
Yeah.
എല്ലാരും ഒന്ന് chat box നോക്കിയാൽ ഇത്രയും കമന്റുകൾ കാണാം.
അല്ല, വിജയകുമാർ അത് ഭയങ്കര അതാണ്, വിജയകുമാറിന്റെ ഒരു ഏരിയ ആണ് ഗ്രോത്ത് ചാർട്ട്സ്. അപ്പൊ ഡെഫിനറ്റ്ലി ഗ്രോത്ത് ചാർട്ട് ഞങ്ങൾ ഇവിടെ ഗ്രോത്ത് ചാർട്ട് എല്ലാ പേഷ്യൻസിനും കൊടുക്കുന്നുണ്ട്. ഐ തിങ്ക് വിജയകുമാർ നോസ് ദാറ്റ്. ആൻഡ് വി ഹാവ് endocrine clinic where all children above the age of 10 years are evaluated for endocrine problems, because after the age of 10 years, so previously Adim Vijaykumar Raynu, now we have Dr. Rajesh and Dr. Priya, so that is continuing being evaluation.
State president ഒരു ചോദ്യം ചോദിച്ചിട്ടുണ്ട്. നമ്മള് ആ ചോദ്യം കണ്ടപ്പം അന്നത്തെ മാനന്തവാടിയിലെ പേഷ്യന്റിനെയാണ് എനിക്ക് ഓർമ്മ വരുന്നത്. In the case of transfusion induced HIV, hepatitis C or hepatitis B in your series, would you prefer that?
That is a very good question. Dr. Narayan ആണ് ചോദിച്ചു. അത് വളരെ ഇമ്പോർട്ടൻറ്റ് ചോദ്യമാണ്, ബിക്കോസ് we had one child who was retropositive, and so you would being in a government servant or retropositive patient, they are on transfusion and they being retropositive and mother and father being negative. So we are in a dilemma. Fortunately for us, the patient had blood transfusion from other areas as well. So we could save our skin, but not the what you call that. It could be from any other, because we are screening all this hepatitis B and C and HIV, but still it could be anything from the window period. So it is every year we have to screen for, as I said in the slide, all this transfusion transmitted infections B and C. But fortunately for us, we had only one case. C is not so common. C, what we see is in leukemia patients, we have seen children hepatitis C, even though the same source and or a blood bank, but hepatitis C is more prevalence in these children with those or leukemia, those children who had leukemias and malignancies.
Ajit, how often you have to screen for hepatitis B or HIV?
We are screening every year. Every year. That's our protocol.
Any window period concept? That's a question from Dr. Geeta.
Window period, like most of them are from transfusion from age of 6 months and onwards. So every year we have to screen. That is for HIV, hepatitis B, hepatitis C. Now the good news is that for hepatitis C, we have a very good treatment options for hepatitis C. Lidipsivir with sofosbuvir combination.
Thank you, Ajit. It was an excellent presentation. അപ്പോൾ ശരിക്ക് നമ്മുടെ PG സമയത്ത് IAP ഹെമറ്റോങ്കോളജി ചാപ്റ്റർ തുടങ്ങി ഒരു PHO റിവ്യൂ, പീഡിയാട്രിക് ഹെമറ്റോങ്കോളജി റിവ്യൂ എന്ന് പറഞ്ഞ 3 months ജേർണൽസില് മമത മംഗ്ലാനിയുടെ ഒരു ആർട്ടിക്കിൾ ഉണ്ടായിരുന്നു 96 ആ സമയത്ത്. അന്ന് അവര് ആ ആർട്ടിക്കിള് കൺക്ലൂഡ് ചെയ്തത് ഇങ്ങനെയാണ്: regular transfusion, prompt chelation, and confident bone marrow transplantation. That is the 3 mainstays of management of thalassemia major. അപ്പോൾ നമുക്കിപ്പോൾ chelation ഉണ്ട്. സമീപ ഭാവിയിൽ ഇപ്പോൾ സെൻട്രൽ ഗവൺമെന്റ് പ്രൊജക്ട് വരുന്നുണ്ട്. ഈ കുട്ടികൾക്ക് ട്രാൻസ്പ്ലാന്റ് നമുക്ക് നടപ്പിലാക്കാൻ കഴിയുമെന്ന് പ്രതീക്ഷിക്കാം. അപ്പോൾ IAPയുടെ റയർ ഡിസീസ് പ്രോഗ്രാമിൽ തലസീമിയ റയർ അല്ലെങ്കിലും ഉൾപ്പെടുത്തിയത് ഒരു നല്ല കാര്യമായിട്ട് തോന്നുന്നു. സ്റ്റേറ്റ് പ്രസിഡന്റിന് ഒരു പ്രത്യേക നന്ദി പറയുന്നു. വി ഷുഡ് പ്രസ് ഓൺ ആൻഡ് ഇംപ്രസ് ഓൺ. പ്രസ് മാത്രം പോരാ, ഇംപ്രസും ചെയ്യണം ഓൺ അഡ്മിനിസ്ട്രേഷൻ ആൻഡ് പൊളിറ്റിക്കൽ ലീഡർഷിപ്പ് ഇൻ സച്ച് തിങ്സ്. ഓവർ ടു ഡോക്ടർ നാരായണൻ.
Thank you, Dr. Ashraf, and thank you, Dr. Ajit, for that wonderful presentation. We have covered the full aspect, all the aspects of thalassemia, and definitely IAP will take rare diseases into the administration side, and definitely we'll be planning more and more programs like this, so that the awareness among the general pediatricians on the rare diseases, they are updated, and definitely that will help the better management of rare diseases. And also one comment I would like to make, that is regarding the NAT tested blood. I am not sure whether it is available in other parts of Kerala. If you are using nucleic acid tested blood, that is available in some of the blood banks in Cochin and all, the window period of these infections, HIV, hepatitis B and hepatitis C, can be drastically brought down. So we had seen in our study that during the last 3 years, we could do NAT testing and we could pick up 27 cases of HIV, combined HIV, hepatitis B and hepatitis C, which would have been missed if you had done only the routine testing. So NAT tests should be encouraged in all institutions. That will definitely, even if it's a single case of HIV or hepatitis C, hepatitis B, will be answerable to that. So as far as possible, promote and encourage using NAT tested blood wherever it is available. So finally, I should thank the Calicut team, and for the vote of thanks, we have our secretary. I don't know whether it is Nihas or Baladra who is doing the vote of thanks.
Bala sir.
ബാലയാണ്. അതിന്റെ മുമ്പ് നിഹാസിന് എന്തെങ്കിലും പറയാനുണ്ടെങ്കിൽ പറയാം. ലാസ്റ്റ് ഇയർ വി ഹാഡ് an iftar meet because of the COVID. ഇനി സൂമിലെ വല്ല ഇഫ്താറും നിഹാസ് പ്ലാൻ ചെയ്യുന്നോന്ന് അറിയില്ല.
ഇല്ല കോവിഡ് ആയതുകൊണ്ട് തൽക്കാലം ഇഫ്താർ മീറ്റ് ഒന്നും പ്ലാൻ ചെയ്തിട്ടില്ല.
Respected seniors, actually it is Nihas who was supposed to deliver the vote of thanks, but he only made the agenda and entrusted the job to me. Actually, so we have completed one more action plan of the 40 action plans of this year 2020. Actually, this is the second program on Widen the Horizon for rare diseases. We had associated with IAP Valvanad and ICONS Shornur. We had a CME on genetics on rare diseases where Dr. Shankar was there, Charity sir was there. And we had a good CME then. So this is the second program. And as Narayan sir said, we will continue with the awareness classes on rare diseases, especially among doctors in the periphery and private sector. First of all, let me thank President Narayan sir for including this very important topic on the action plan. Next, I would like to thank our speaker Ajit Kumar sir for his excellent presentation. His experience in treating thalassemia patients has been reflected in the talk today. And I also thank our friends in Kozhikode, Ashraf sir, Nihas, Ranjit, who planned this meeting and made this actually the presidential action plan. And I also thank all seniors, past presidents of AP Kerala for attending this program. Again, today we touched close to 100, and this has been live on. This has been live on YouTube also. Tomorrow we have another action plan, presidential action plan, lateral thinking, the right thinking for doctors by Binoy sir, the president of IAP Malanad. Something different from what we have seen so far, non-medical, and I hope it will be very useful to our members. So I thank everybody for attending this, and we'll have dinner and fellowship at home. Thank you.
Yeah.
Thank you.
Thank you. Once
again,
thanks to State IAP for giving this program to giving the opportunity for IAP Calicut to host this program. Thank you.
നല്ല അറ്റൻഡൻസ് ഉണ്ടായിരുന്നു. 99 വരെ പോയി, 100 എത്തിയില്ല.
100 plus
യൂട്യൂബിൽ 10 ആളും കണ്ടു, യൂട്യൂബിൽ 10 ആളും കണ്ടു.
Attendance is more than 110. Great.
110.
Tomorrow also, it's Saturday evening, we have a wonderful different program. All should come. All are invited.
ഇപ്പൊ ഇത് കുഴപ്പമില്ല, സാറ്റർഡേ ഡ്രൈ ആയതുകൊണ്ട് കുഴപ്പമില്ല. സാറ്റർഡേ ഈവനിങ് ഒരാളുണ്ടാവും.
ഇപ്പൊ എല്ലാ ദിവസവും സാറ്റർഡേ സൺഡേ ആണല്ലോ. ലിഹാസിനല്ല കേട്ടോ, ലിഹാസ് ഇസ് വെരി ബിസി.
അല്ല, എനിക്കില്ല.
ഇല്ല, ഓൺലൈനിൽ ഇപ്പൊ കിട്ടും. ഓൺലൈനില് ഉടൻ തന്നെ വിതരണം ചെയ്യുന്നതാണ്.
Okay, good night.
Okay, good night.
Good night.